welcome to today's online seminar, Getting to the Heart of Pediatric and Congenital Cardiology. My name is Stavroulas Avelidis, and I'm the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. Before we get started, I'm going to go through some housekeeping to ensure a smooth and successful virtual presentation. Firstly, everyone will be muted during the presentation so as to avoid any background interference or interruptions. Secondly, if you wish to ask the presenter a question, please click on the chat box at the bottom of your screen and enter your question. Our staff will read the questions to our speaker, and he will answer them at the end of his presentation. I would now like to welcome our speaker for today. Dr. Shailendra Upadhyay is the Division Chief of Pediatric Cardiology at Connecticut Children's and the Associate Professor of Pediatrics at the University of Connecticut School of Medicine. He's board certified in internal medicine, pediatrics, pediatric cardiology, adult congenital heart disease, and electrophysiology. Aside from adult congenital heart disease, his clinical and research interests include non-fluoroscopic catheter ablation of arrhythmias in children and adults with congenital heart disease. Welcome, Dr. Shea. We are so glad you could be here today to share your insights on pediatric and congenital cardiology. So let us get started. The floor is yours.
Thank you, Ms. Avelidis. Thank you, Nassau County Society, for giving me this opportunity to be here and present. It's a true pleasure and honor. I also want to thank Alexa. So we'll get started. I have no disclosures. I want to share that, the pediatric cardiology is really not just pediatric cardiology, but it's an evolution that starts from the fetal life and goes up to involve caring for the newborns, toddlers, preschoolers, primary school children, and then you go up to the adult and the adolescent age group. The congenital heart diseases, which were diagnosed even before the babies are born, most of them are living up to being adults now, and of course elderly. So the pediatric cardiology is really a spectrum, starting from fetal cardiology to neonatal and pediatric cardiology, adult congenital heart disease, and then acquired heart diseases, examples including myocarditis, rheumatic heart disease, and chemocardiotoxicity. And then heart rhythm disorders, so you can have electrical disturbances of the heart, and other organ systems that interact with the heart may present with several symptoms that the physicians may deal with on a day-to-day basis, including things like syncope and postural orthostatic tachycardia syndrome. And lastly, this is the COVID era, and the talk cannot be complete without having discussed something about COVID and the heart, particularly in the pediatric cardiology population. So one of the easiest ways when I was learning as a medical student or a resident to understand the heart was I thought of the heart as two pumps. There's a pump on the right which collects all the blue blood from the body and then pumps it out to the lungs so they can get oxygenated. And then once they receive oxygen, the left pump on the left side will pump that oxygenated blood to the body. And there are various barriers that separate the right and the left pumps. There's a wall that separates the top chambers, the atrial septum. There's a wall that separates the bottom chambers, which is your ventricular septum, and the great arteries that go to the lung and the aorta are also separate, but in the newborn period, they have a connection which connects them, which can persist in later life as well, which is referred to as a ductus arteriosus. And you can have certainly holes between the walls that separate the chambers, or you can have chambers of the heart that are underdeveloped, and that can lead to various manifestations. So we'll start off with the fetal cardiology. So the cardiology really starts even before the babies are born. And I think it's one of the great successes of medicine and pediatric cardiology per se, that we can diagnose both defects even before the babies are born so that we are ready for taking care of them once they are delivered. So fetal cardiology evolved along with a part of doing obstetric ultrasounds, and later we learned that we can really look at the baby's heart. It helps us diagnose congenital heart defects. It also helps us diagnose fetal arrhythmias. So the babies, just like older people can have rapid heartbeats, the babies can have that too, or they can have heart block where the conduction system has not well developed. All of these can be diagnosed in the fetal life, and you can prepare the delivery and manage the baby after they're born. It's really important to have these diagnoses from the get-go so that you can plan whether the babies can be delivered at a safe non-tertiary care center or they really need to be delivered at a tertiary care hospital. This is a busy small type thing here. It just tells us what risk factors in the mom can lead to congenital heart defects in the babies, and that those babies need to be screened with a fetal echocardiography. And again, just like, you have to specialize and make definitive ways of making the diagnosis and looking at the heart. There are various views that are developed to look at the baby's heart with the fetal echocardiography. A few words about the fetal circulation. So there are major differences between the fetal circulation and the circulation after the babies are born. We know that as the babies don't have their own lungs that can help them receive oxygen. So the oxygen is delivered by the placenta from the mom. And then the right ventricle and the left ventricle have similar contributions to the systemic circulation. So the blood that returns back to the right side of the heart through the PFO and the PDA, the right heart also contributes by pushing that blood out through the pulmonary artery and PDA to the descending aorta. And through this PFO, where the oxygen-rich blood, which returns from the placenta, is actually pushed through this PFO to the left heart and to the brain, so that the more oxygenated blood can go to the brain and the brain can develop. We know that both ventricles pump similar resistances. So unlike in the adolescent or the adult life, the lungs are high resistance circuit. So there's a higher pressure that the RV needs to generate to pump blood out, which is similar to the one on the left side. So they tend to have similar resistances. There are normal shunts that exist in the fetal life, which could be unusual or considered unusual in older ages. It's a patent foramen ovale or a foramen ovale. It's a communication between the wall that separates the top chambers of the heart. You have something called a ductus venosus, which is a connection from the umbilical vein into the area of the inferior vena cava. And then you have something called the ductus arteriosus, which connects the pulmonary artery to the aorta. And how do the fetuses survive with congenital heart disease? Well, the normal fetal circulation involves lots of mixing. So, even if you have one of the chambers that's small, or the other chamber that's not as what you would expect it to be, the blood can still flow to different areas that require growth. Critical obstructions. So for instance, if you have severe aortic valve stenosis, the blood can still go to the aorta through this patent ductus and feed both the proximal and the distal ends. And for this very reason, even if you don't have two ventricles, you can really survive with one ventricle with all these connections in the fetal life. Moving on to neonatal and pediatric cardiology. So this is going to talk about the differences that happen after the baby is born. So in transitional circulation, what happens is after the baby is born, the baby's lungs are the source of oxygen now, and no longer it is the placenta. And the pressure in the left atrium goes up a little bit, which leads to for a functional closure of the PFO or the foramen ovale. And the ductus arteriosus also closes between 48 and 72 hours. In neonatal circulation, again, the way it's different from the fetal circulation is that the right ventricle pumps blood to the pulmonary circulation, and the left ventricle pumps blood to the systemic circulation now, and there's no mixing anymore. Both the right ventricle and the left ventricular outflow resistances at birth are higher because the lungs have still not dropped all the pressure. They have just recently been unsoaked from being wet and high resistance circuit. And the RV and the LV pressures are therefore not much different at birth. At about 6 to 8 weeks of age, the pulmonary vascular resistance drops to the usual adult levels, and the RV pressure will drop then. And it's important to keep some of these things in mind because this has implications on when the babies would present. Then the main difference between the neonatal and the pediatric and the adult circulations is that the LV pressure becomes much substantially higher than your RV pressure. The left atrial pressure is also slightly higher than the right atrial pressure. And if you were to have communications or holes between the atria and the ventricles, the preference for the blood would be to flow from the left to the right side. And we know that the RV pumps against a low pressure resistance now because the pulmonary vascular resistance has fallen. And the RV is also a more compliant ventricle than the left ventricle. Congenital heart disease is a major problem. It affects about 1% of live births in the USA each year. And we also know that the prevalence of the mild types of congenital heart disease is going up, whereas the other types has remained stable. And ventricular septal defects, or the hole between the wall that separates the bottom chambers of the heart, is the most common type of congenital heart disease. Moving on to critical congenital heart disease, it's really important to understand and recognize this because 25% of the babies born with heart defects have critical congenital heart disease. And the way we think or define the critical congenital heart disease is that these are the patients who will need some kind of an intervention within the first year of life. And annually in the USA, about 7,200 babies are born with critical congenital heart disease. And one of the things or the advantages we have in patients with critical congenital heart disease is often they tend to have low oxygen saturations due to the mixing, and it can be picked up with a simple test called pulse oximetry. And how do we perform pulse oximetry? So we check the oxygen saturations in the right hand and the foot. It does not replace a physical exam. So clearly you have to combine the physical exam and the findings of the pulse oximetry to detect the underlying type of heart defect. And again, we also have to know that not all critical congenital heart defects can be picked up with pulse oximetry, but we will pick up some of the major ones. And what was classically described as the heart defects you would almost certainly pick up with pulse oximetry are something called hypoplastic left heart syndrome, where the left heart hasn't developed well. So you're going to have trouble supplying blood to the systemic circulation. Pulmonary atresia, where the right heart hasn't developed well, so you're going to have trouble supplying blood to the lungs. And then tautology of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, tricuspid atresia, and truncus arteriosus. Some will say that, the 5 T's, which are these, the bottom 5 options here. How we do the pulse oximetry? So it should be done near discharge, or at least after 24 hours of birth. And the way the screening works is you check saturations in the right arm and the foot. And if the saturations are above 95% and there's no difference in the saturations between the arm and the leg, or if the difference is there, it's less than 3%, you retest in an hour. And then if it's still the same, retest in an hour. If it's fine, you clear the child with having passed the pulse oximetry test. If the saturations are below 90%, you recheck in an hour. If they're still below 90%, recheck in another hour. If it's still below 90%, they have failed the screen, and they should undergo further evaluation for critical congenital heart disease or other mechanisms that can cause desaturations, which could be non-cardiac. If the saturations are between 90 and 95%, you still don't pass it. Or if you have a more than 3% difference between the upper and the lower extremities, you wouldn't pass the test. And the idea is to repeat it again in an hour, and after an hour, if it's more than 95%, retest in an hour, you're fine. If it's below 90, retest in an hour, below 90, you fail. And again, in an hour, if it remains the same, which means that the saturations are between 90 and 95 in the right arm and the leg, and or there's a more than 3% difference. If it continues after 1 hour and another hour, then you fail the screen, and you need to undergo further evaluation for complex congenital heart disease. So we also need to recognize that the congenital heart disease related deaths are leading cause of birth defect associated infant illness. And the deaths due to congenital heart disease often occur in the newborn period in less than 28 days of age. In one study, about 4.2% of all neonatal deaths were due to congenital heart disease. And nearly half of these deaths due to congenital heart disease occur within the first year of life. So it's crucial to diagnose them in the neonatal period. And if they have somehow been missed, you should certainly make a diagnosis before a year of age. Otherwise, it's a major mortality contributor. This is a slide showing us the timing of diagnosis by critical congenital heart disease. So critical congenital heart disease, as we know, makes up about 25% of all of congenital heart disease. And in this particular study, what they showed was that 56% of these were prenatally diagnosed. So you were ready to take care of these babies, with the help of fetal echoes. About 31% were diagnosed after they were born in the hospital with the help of a physical exam and pulse oximetry, and about 12% of them were still missed, and they were a delayed diagnosis. And if you look at the classification of different cardiac conditions, all the 7 things that I previously talked about were the ones that you could diagnose with pulse oximetry. There's still other conditions, including things like AV canal defect or coarctation that can be missed despite the pulse oximetry screening that can be diagnosed later. A few words about the ductal dependent lesions. So, the ductus, as I mentioned previously, is a communication between the pulmonary artery, or the great vessel that goes to the lungs, and the aorta, the great vessel that supplies all of the body oxygen-rich blood. This communication is critical in providing blood flow either to the body or to the lungs in case there's deficiency there. If the right heart has not developed, the way to get blood to the lungs would be through the ductus, or if the left heart or the aorta has not developed, the ductus is the source of supplying blood. And if you have situations where the blood flow to the lungs is limited, such as critical pulmonary stenosis, pulmonary atresia, intact ventricular septum, patients with Epstein's anomaly, or severe forms of tetralogy flow, such as tetralogy flow with pulmonary atresia, these patients will have no blood flow to the lungs after the PDA closes, and they won't do well. And similarly, if you have certain conditions such as critical aortic stenosis, there wouldn't be much blood going out to the ascending aorta, and there will be poor perfusion. Now, your blood is going to the lungs, so your saturations will be fine, but you're going to have a poor perfusion. Other conditions include interrupted aortic arch, severe coarctation, or hypoplastic left heart syndrome. And then you have certain conditions where you have a ductus which acts as a source of mixing the blood so that it doesn't result in immediate catastrophe. Conditions such as detransposition of the great arteries, once the ductus closes, the right and the left heart will not connect in terms of blood supply, and the person won't do well. Prostaglandins, of course, the prostaglandins were wonder medications discovered in early 1970s. They help us keep the PDA open. The advantage of this medicine is that even if the patients are a new diagnosis and they're not in a tertiary care center, they can be started on prostaglandins to help with either the pulmonary circulation to ensure blood flow to the lungs, or with the systemic circulation, or to ensure blood flow to the body. And the patients can subsequently be transferred to another facility with all the equipment and the services ready to take care of complex congenital heart disease. We have to know that one particular condition called total anomalous pulmonary venous return, if you put them on prostaglandins, it doesn't help, and it may actually deteriorate the situation because it causes more blood to go to the lungs, and the outlet from the lungs is not working. When we suspect heart disease in the newborn period, so assuming that you have a fetal diagnosis made and those patients have all been referred, and at times you may still have patients that can slip through and they may have critical heart disease. There are two things, if you keep in mind, will help you think through or discern what the underlying complex congenital heart defect may be. Just know that the PDA closes by about 3 days of age. So PDA dependent lesions, whether dependent to the lungs or to the body, will manifest at about 72 hours or early within the first week of life. And if you have some other critical cardiac conditions which are not ductal dependent, that just know that by about 2 months of age, the pulmonary vascular resistance will drop, meaning if you have holes between the bottom chambers or great vessels, the blood will prefer to flow from the high pressure to the low pressure. For instance, a patient with AV canal defect or large VSD will start shunting blood from left ventricle to the right ventricle and will lead to what is called pulmonary overcirculation and heart failure symptoms. This is a slide just telling us what times or when should we suspect congenital heart disease. If you have heart murmurs that are loud, it could be from a PDA, but it can also be from obstructive lesions such as pulmonary stenosis or aortic stenosis. If you have cyanosis, it means that both the oxygenated and deoxygenated blood is mixing at some point or somewhere. If they failed the CHD screen with pulse oximetry, if you have poor pulses in extremities, which will mean that the perfusion has been impacted somehow, or if you have other suspicious signs such as respiratory distress, poor feeding, gray or pale color, which means that the perfusion is not good. Someone once taught me that patients with congenital heart disease come in 3 colors, blue, gray, and pink. And what blue means is there's lack of blood flow to the lungs. So if you're not getting enough blood flow to the lungs, you're not getting adequate oxygenation, the baby is going to be appearing blue. So situations where you have a small right heart or a small diminutive vessels supplying the pulmonary arteries, you're going to be blue. The examples include tetralogy flow. And when you get a chest X-ray on these patients, the lung fields, because they lack oxygen, are going to appear dark. On the other hand, gray is a color when you have lack of blood flow to the body and poor perfusion. And often these patients may have a heart murmur related to obstruction to the aortic flow, or they may have a coarctation and may have poor pulses or differential pulses between the upper and lower extremities. And pink. Pink babies with heart defects are the ones that have no duct-related issues or no specific issues in terms of the blood going to the lungs or the body, but they have higher pressures on the left side and lower pressures on the right side. So the more blood is going to flow to the lungs, leading to overcirculation, and it can cause heart failure symptoms. And then there are certain situations where you have blood flow going to the wrong places, where they can have profound cyanosis, tachypnea, and a murmur. Examples include transposition of the great arteries, TAPVR, and so forth. I'm going to skip this slide. It just talks about non-ductal dependent critical congenital heart disease, truncus arteriosus, and TAPVR. And to be honest with you, each of these topics by themselves, or titles by themselves, are like a couple of hours of a talk. So we'll keep it limited, so we get the point, but not necessarily understand all of congenital heart disease. Just an example of a blue baby. So this is an example where the right atrium is fine, but the right ventricle is really small because it had no outlet. There was pulmonary atresia. So as there's no forward flow, the RV doesn't get enough flow of blood to come through it, and it becomes underdeveloped. And this patient, if they're not immediately paid attention to, once the duct closes, that which was supplying your pulmonary arteries, they'll have no blood flow to the lungs, and they'll become severely cyanotic and die. This is an example of a gray baby or poor perfusion to the body, where you have a left heart which is underdeveloped, ascending aorta is underdeveloped. So the way the blood is getting to the entire body is the blood coming from upper half, lower half of the body, going to the pulmonary artery, and through the ductus, it's supplying the descending and ascending aorta. And once the ductus closes, you can imagine there'll be no flow to the ascending or the descending aorta, and the baby will have no perfusion and will die. This is an example of a pink baby. So here you have a hole in the wall that separates the bottom chambers of the heart, or the ventricular septal defect. When the babies are born, because the pressures are equal, there wouldn't be much shifting of the flow of blood in either direction. But at about 2 months of age, the PVR drops, and now it's much easier for the high pressure blood from here to come through this VSD and go and flood the lungs, so they will develop pulmonary overcirculation or heart failure symptoms. It's another example of a complex congenital heart disease or critical congenital heart disease that could actually be missed even with pulse ox screening at birth or physical exam, because there may not be a murmur. So moving on to the adolescent and adult congenital heart disease. As we have learned that most common form of birth defect is congenital heart disease, about 1% of all births. With the advances in pediatric cardiology, diagnosing from the fetal age to the surgical techniques to the post-operative care, neonatal care, and regular follow-up, almost all of the kids that had congenital heart disease are living up to being adults now, and they can do whatever they like, almost all of them. Just an example of some wonderful personalities. We know Shaun White, who's an Olympic skateboard champion, had teratology fellow. Arnold Schwarzenegger had left heart obstructive lesions. Mark Miller, who's an MMA fighter, had a complex surgery repaired. And Brian Littrell, Backstreet Boys, also had a VSD that was repaired. So if you think about it, the incidence is about 1 in 100. So if you're sitting in a room full of 100 people, one of them has congenital heart disease. So it's very, very common. And this is an epidemiology on the survival. So before 1960s, barely any patients who had transposition of the great arteries lived up to being adults. And now almost 90 to 100% of them will survive to become an adult. And it's not just with transposition, but almost all forms of complex congenital heart diseases who were born, the kids who were born with that would become adults now. The prevalence keeps increasing, over 1.5 million now, adults with congenital heart disease living in the USA. And this is another wonderful slide. If you look at 1960s, there were more children, about 70% children, 30% adults with congenital heart disease living in the USA. Now in 2005, we crossed over. There are more adults with congenital heart disease living in the USA now than children. This is another slide just demonstrating the adults versus the children and the survival. As we can see, there were there were more children, and as adults they were, the population was declining. But now all those children are becoming adults, and there's an enormous growth in the population of adults with congenital heart disease. And there are many reasons responsible for this. Of course, the prostaglandins were discovered. So even if you diagnose a complex congenital heart disease in a remote place without services, they can be started on prostaglandins and transferred to a place where the complex congenital heart defects can be taken care of. We have improved diagnostic modalities. Now we can diagnose congenital heart disease even before the babies are born with fetal echoes. We have improved surgical techniques, single ventricles, which people couldn't imagine repairing 40 years ago. They all undergo surgery and get repaired now, and post-operative and neonatal care. And it's not just that; there's also interstage mortality. Some of the congenital heart defects will require multiple surgeries, and the patients may die in between those stages. And so we have developed programs among different institutions called the single ventricle program, where there's nursing, there's social work, and there's family education. All of that comes together in ensuring survival in these patients. We just know that adults with congenital heart disease are repaired, they're not cured, and they have lifelong issues, which can be limited not just to their heart, but other things such as, because the population is increasing, they want to have families, they can get pregnant, and they represent higher pregnancy risks. They can have internal medicine issues that can be superimposed on their pre-existing conditions. And oftentimes, in the previous era, most of the people were told that they can't exercise too much, or they shouldn't participate too much in physical activities. And many of them have become sedentary, and obesity and metabolic syndromes are also common in this age group. So just know that this population is increasing, and there's increasing demand in every aspect of care, not just heart disease, but internal medicine and other services. So acquired heart diseases. So I was trying to be very optimistic and thinking that I could cover all of this, but I think it's going to be impossible to cover all of these topics. So I'm just going to share and mention some of the names. Myocarditis and pericarditis is an example of acquired heart disease. Vasculitis, Kawasaki disease, and lupus, which can involve the coronaries or the heart valves. Chemocardiotoxicity. Just know that cancer is the second most common leading cause of death in children in the USA. And many of the cancer treatments involve medications such as anthracyclines that cause myocardial dysfunction. So it's kind of an evolving field, and our place here offers a wonderful program geared towards children with chemocardiotoxicity. Rheumatic heart disease. It used to be very common, in the pre-antibiotic era, and still is a major problem in developing countries. But we don't see as much of rheumatic heart disease in the USA at this time. Heart rhythm disorders and interaction of other organ systems with the heart. Heart is a pump, and as we know that any pump requires electricity to travel through it. The electrical system of the heart is crucial in optimizing the heartbeat, in giving adequate number of heartbeats, and making sure the electricity travels through the top to the bottom chambers. So the problems can be from too slow a heart rate, or the bradyarrhythmias. The examples of bradyarrhythmia in children include sinus node disease or AV nodal disease. So sinus node disease means that you have a problem with the way the beat is being produced from the right top chamber. And sinus node dysfunction leads to very slow heart rates, or sinus pauses, meaning you don't have a heartbeat for a while. In pediatric population, the reasons for the sinus node dysfunction include either an abnormal development or abnormal placement of the sinus node. There's a group of conditions called heterotaxy syndrome, where you could have atrial inversion, you can have absent superior vena cava, and these patients can have abnormal or absent sinus node. You can have sinus node injury or dysfunction from heart surgery. So oftentimes when we perform many of these operations, such as ASD closures, which are closer to the superior vena cava, or we do certain operations called the Fontana operation, where you disconnect the superior vena cava, if you're doing surgeries which involve the blood flow to the sinus node artery, all these can lead to sinus node dysfunction, often necessitating insertion of a pacemaker. If you don't have an issue with the sinus node, you may have an issue in terms of the heartbeat traveling from the atria to the ventricles. So as we know that the AV node is a junction that facilitates transfer of the beat from the atria to the ventricles, you may have an AV nodal disease in children, which we commonly know as heart block, where the atria and ventricles electrically do not communicate with each other. One of the famous ones, and it's a common question on USMLE, is what's the cause of heart block in a baby? It's maternal lupus, and the antibodies related to the lupus can cause heart block. And this kind of diagnosis is sort of close to my heart, because this was described by the person who started the pediatric cardiology program here at Connecticut Children's, Dr. Leon Kamaitis. It always reminds me of him when I see that as a cause. We know the infectious causes, the bacterial, viral, and parasitic. We all know of Lyme disease, which can cause AV block. So if you encounter a child with Lyme disease, it's always a good idea to rule out, if you encounter a child with heart block, it's always a good idea to rule out Lyme disease as a potential mechanism. Long QT syndromes can also present with heart block. One of the most common reasons for heart block is, again, post-surgical, repair of the ventricular septal defect, AV canals, left ventricular outflow tract, or sometimes after catheter ablation, if you're ablating very close to the AV node, you can cause heart block. There are certain congenital heart defects that may have abnormal position or abnormal development of the AV node, which can cause heart block, such as L transposition of the great arteries. There are certain syndromes like Holt-Oram syndrome or Kansar syndrome can result in AV node dysfunction and heart block. Neuromuscular diseases, muscle dystrophies can also develop heart block. Now, rapid heartbeats on the other end. So rapid arrhythmias or supraventricular and ventricular arrhythmias. So in terms of the rapid arrhythmias, a fast heartbeat, supraventricular tachycardia is the commonest form of tachyarrhythmia. And there are many mechanisms to SVT, but the most common mechanism is by a re-entry, meaning there are two pathways of different conduction properties, and the arrhythmia circulates between the two. In postoperative patients, you can have automatic arrhythmia, as a well-known thing called junction ectopic tachycardia after repair of congenital heart disease. Ventricular arrhythmias are less common. Idiopathic VT or ventricular tachycardia that occurs in absence of structural heart disease can be seen. Some of the examples are outflow tract ventricular tachycardia or fascicular ventricular tachycardia. And patients who've undergone repair for complex congenital heart disease, such as sertology or Fallot, at times can have re-entry mechanism, ventricular tachycardia. There are some examples of mechanisms of supraventricular tachycardia. You can have AV node re-entry, where you have a re-entry that happens around the AV node. You can have pathways, accessory pathways on one or either side of the ventricle, so the beat can go down the AV node and come up that accessory pathway, or it can do the reverse, go down the accessory pathway, come up the AV node, or you can have a focal arrhythmias originating from one of the top chambers of the heart, or you can have a fibrillation, meaning multiple areas getting activated from the pulmonary veins or atria or the different veins. Or you can have multifocal atrial tachycardia originating from different places in the atria. This is an EKG, just an example of a narrow complex tachycardia. As electrophysiologists or people who are more interested in cardiology, you often try and find the P waves. And in this particular example, you can see small P waves right there. And if the P waves are squished into the QRS complex, or they're very close to the beginning of the QRS complex, often it represents AV node re-entry tachycardia. And the other type of tachycardia called orthodromic reciprocating tachycardia, where the beat goes down the AV node and comes up the accessory pathway. One of the EKG features to distinguish that is the P waves are further away from the QRS complex. So some subtle clues can tell you what the underlying mechanism of SVT may be. This is an ECG of a patient with Wolff-Parkinson-White syndrome. You can see a short PR interval, a delta weight and a wide complex, and you can actually see loss of pre-excitation, a loss of WPW in some of these beats, where you can see the normal ECG in this patient. So just know the patients with WPW syndrome or Wolff-Parkinson-White can have rapid arrhythmias as well. An example of idiopathic VT or ventricular tachycardia in patients with structurally normal heart. This is a A patient I cared for, he was about 15 years of age, and we can see normal narrow complex beats followed by wide complex rhythm. We know that the outflow tract arrhythmia, so this is just a cross section of the heart. You have the mitral valve on the left side, tricuspid valve here, and that's the aorta and the pulmonary artery. And this region is referred to as the outflow tract. And the idiopathic VTs may originate from the outflow tract of the heart. And then first we treated this patient medically, but he continued to have some arrhythmia burden, about 4.2% on his Holter here. He had ventricular dysfunction as well, so I took him to the EP lab. He was noted to have ventricular arrhythmia from the cusp of the aorta, and this is just a fluoroscopy showing the origin from the aortic cusp, which was successfully ablated. And at follow-up, the patient had no further arrhythmias, 0% AICP burden. So he was cured. So, some of these idiopathic arrhythmias, if we identify and find the right location, we can cure them with catheter ablations. Syncope. So, I'm not going to talk about vasovagal syncope here, but I'm going to talk about what EKG clues can we get in patients of syncope that may point or give us some clues towards it being a cardiac mechanism. So the way I approach ECG in patients who come in with syncope and whether there's a cardiac involvement, it can be clues from the EKG to it being a primary arrhythmic event, or it can be clues from the EKG to tell us that maybe this was a mechanical arrhythmic event, meaning some mechanical abnormality with the heart that can lead to arrhythmias. So examples of tachyarrhythmia, and some of these are included or called as cardiac channelopathies, is you can have Brugada syndrome, which is issues with the sodium channel in the heart, which can lead to malignant ventricular arrhythmias and ventricular fibrillation. Long QT syndrome, where there's abnormal repolarization and delayed repolarization, which can lead to ventricular fibrillation. Short QT syndrome, again, where the QT syndrome interval is short and can lead to arrhythmias. Catecholaminergic polymorphic ventricular tachycardia, it's a defect of what we call the ryanodine receptors, where they can have life-threatening polymorphic arrhythmias. Wolff-Parkinson-White syndrome, these patients can have SVT, and they can, if the pathway can conduct very rapidly, atrial fibrillation can degenerate into life-threatening arrhythmias. And you can have some of the progressive conduction disorders, which is not so much of a problem in pediatrics, but more of an issue with the adults. Bradyarrhythmias, of course, they will have a positive physical exam. Just know that these patients may have a completely negative physical exam, and the EKG is the one that will give you the clues. In terms of bradyarrhythmias, the patient will be bradycardic. You can have sinus node dysfunction, pauses, you can have heart block. And then with mechano-arrhythmic, you can have conditions such as hypertrophic cardiomyopathy, rhythmogenic right ventricular dysplasia, where the ventricular myocardium is replaced with fibrofatty tissue. You can have anomalous origin of the coronary arteries, where the coronaries can get compressed between the great arteries and lead to abrupt short ischemia and arrhythmias. And Kawasaki disease can cause myocardial infarction if there are giant aneurysms, and all of these can cause arrhythmias. Just an example of a 11-year-old patient that I took care of. He was playing basketball and had syncope. His father, who had learned CPR that very particular day, was able to use it on his own son, and this was his ECG. And what's remarkable is that there's a very long QT interval of 530 milliseconds. So this patient was treated with beta blockers. He also got a what we call the secondary prevention ICD because he had a cardiac arrest. So moving on, dysautonomia and POTS. The only reason I have included this is because it's something that all of us will see in any kind of practice, whether we internists, pediatricians, gastroenterologists, cardiologists. For some reason, cardiologists, get the credit of being the specialist on these. I'm not sure if they truly are, but it's something I just wanted to bring up because it's a very common problem. And the way we define postural orthostatic tachycardia syndrome is, when you make a person stand up from laying down position, there should be at least a 30 beats per minute increase in the heart rate in the adult age group, or 40 in children. And we also want to make sure there's no orthostatic hypotension, because that would be against POTS. And often they will have frequent symptoms with standing, which include lightheadedness, palpitations, tremulousness, generalized weakness, blurred vision, exercise intolerance, and fatigue. And people have tried to categorize it and define different types of POTS. They could be what we call the neuropathic POTS. It could be related to some autoimmune disorders. It could be hyperadrenergic POTS. It could be related to mast cell activation disorder, which is kind of controversial. You can have volume dysregulation, and many of these things can contribute to the POTS symptoms. And there are many associated conditions, with POTS. Often you'll see that the patients may have chronic fatigue syndrome, concussion, migraines, fibromyalgia. They may have functional GI disturbances, anxiety and hypervigilance, autoimmunity, joint hypermobility, and Ehlers-Danlos syndrome. So there are many conditions that can coexist in patients who have POTS. And also know that there's some new reports coming out that COVID may trigger POTS symptoms too. So in terms of diagnosis, I think what's crucial is to make sure we're not missing on any other things, such as a thyroid disease, anemia, because they can have very similar manifestations and presentations. And within patients who also meet the criteria for changes in the heart rate upon standing and having all these symptoms, make sure they don't have other conditions referred to as the inappropriate sinus tachycardia, and make sure they don't have orthostatic hypertension at the same time. And they have stable heart rates, but their blood pressure drops. Treatment algorithm. I wish there was a magic bullet for POTS. There isn't one. And the treatment always starts with non-pharmacologic methods, hydration, exercise. Exercise is the one that probably helps better than anything else. If the symptoms are dominated by different groups, targeting those different groups may be beneficial. So for instance, if your symptoms are predominantly palpitations, you can start a small dose beta blockers on them, and one of the new medicines called the ivabradine. If they have low blood pressure issues, you can consider midodrine. And if they also have associated constipation, you can use some anticholinergics like mestinon. If the symptoms are dominated by standing or fog-like sensation, you can use norepinephrine reuptake inhibitors like bupropion or stimulants as well. But the stimulants can also cause further increase in the heart rate. So it's just a tricky situation. So lastly, a few slides on, I think I'm okay on time, so I should be able to get through these. I think it's really important in this day and era to talk about COVID and the heart. And, the COVID and the heart has numerous involvements, but I'm going to stay focused on how it impacts the pediatric and population and the adolescents. We'll talk about the multi-system inflammatory syndrome in children. So, starting off with the definition. So MISC is defined as having 6 criteria. The first is the serious illness leading to hospitalization. Under 21 years of age, you have to have fever or at least subjective reported tactile temperature lasting more than 24 hours. You should have laboratory evidence of inflammation. You should have multiple organ involvement, and there should be no alternate explanation for all these symptoms. And then you should have confirmed lab SARS-CoV-2 infection, such as positive SARS-CoV-2 RT-PCR, or antibody test while the patient is admitted, or an epidemiologic risk to a person with COVID-19, meaning having had contact with someone who had COVID-19. What's the epidemiology? So this is from one of the JAMA papers from last year. So it said about 0.03% of SARS-CoV-2 infection patients will develop MISC. We also know that the risk of developing MISC is higher among Black, Hispanic, and Latino, and Asian or Pacific Islanders. And what's striking in this paper, which was published in New England Journal of Medicine in 2020, is of all the patients who were admitted with MISC, about 80% of them will have some or any cardiovascular involvement. So it's not a small number. If you have MISC, 80% have cardiovascular involvement, and it's only second to the GI involvement. So cardiac involvement is very, very common. This is just a look at the numbers. So this is me accessing the CDC just a couple of days ago, and the total MISC cases in the US were 6,431, and there were 55 deaths related to MISC. And as we can see here, New York has cases in the range of 200 to just under 300. California has the most cases at this time of over 400. This is again a look at the daily cases. So if you see here, this dotted bar in the bottom tells you the number of COVID-19 cases in sort of 100, 200, 300, 400K. And the blue tells you the number of the MISC cases in in sort of teens and 10s and 20s. So if you see, it kind of correlates with as your overall COVID cases are going up, the MISC cases are also going up. And what we see here is, the COVID-19 cases, we don't know what this data is only until January 3, and these are like hypotheses and projections. We don't really know which direction it's going to go. But the hope is that, maybe the COVID vaccine prevents MISC. We don't know that yet, but, that's the hope. If that happens, I think the MISC cases may go down. This is by age group. We just know that the MISC is very common in children between 5 and 11 years of age. And it kind of goes in either direction, beyond that age group. So this is about the epidemiology in children. Again, children between 5 and 11 years of age are as likely to be infected with SARS-CoV-2 as adults. They are at risk of severe illness from COVID-19. They're 3 times higher. They have 3 times higher rate of hospitalization, and about 1/3 of the hospitalized children in this age group require ICU admissions. And MIC is most common in this age group. So just know that getting COVID in the age group of 5 to 11 has lots of problems. The good news is that this is, again, data from the article that was published in JAMA. The patients who had ventricular dysfunction related to MISC, they all recovered with treatment. And and also the ones that, one of the other things we monitor for is coronary ectasia, and the patients who had coronary ectasia also recovered. And, different institutions have different protocols as to what to do with these patients. Often, they'll receive steroids, they'll receive IVIG and aspirin, which is what our program does as well. I wanted to share this because, some people think that COVID-19 mortality is not so much of an issue in pediatrics, but this is data showing the causes of death and, crude rate in children. So the most common reason is accidents, and the next is malignant neoplasms. If you come down here, suicide is about 66 or 0.2 per 100,000. COVID-19 related deaths in children between 5 and 11 are 66. So it has become one of the sort of the leading causes of death in this age group. This is just an example of an 8-year-old child that I've been taking care of. He presented with palpitations, did not really had exposure to COVID several months before he presented with this. You can see all kinds of narrow complex and wide complex and tachycardia. There are other rhythm strips where he had polymorphic runs of VT. And first, because he never had any symptoms, and at the time of the admission, he tested negative for COVID. I thought, maybe he has something like catecholaminergic polymorphic ventricular tachycardia. We tested him for COVID antibodies. He ended up being positive. And again, this is a cardiac MRI done on him that showed myocardial inflammation. So, it may have subtle or different presentations. So you may have a child with COVID-19, unrecognized previous infection, who does have changes seen on the MRI and is having arrhythmias. This child is doing better now, just managed with medications, and the inflammation has also settled down over the last several months. This is the last part of the discussion. I think we should be able to finish it in time. The mRNA vaccination for SARS-CoV-2 myopericarditis. So this is our, sharing some of the experience we had at Connecticut Children's. So we know the clinical trials for the vaccines began in April of 2020, and they entered phase 3 in November 2020, and then FDA grants emergency use in December 11, 2020. And Connecticut makes vaccines available to 16 and 17-year-olds on April 1st, 2020. On May 1st, we had our first case of myopericarditis. And then on May 10, just about 9 days later, the FDA expands emergency use authorization for 12 and above. And on May 17, just 17 days from the time we saw our first case, CDC reports myocarditis possibly associated with vaccination. And the first reports of the vaccine-related myopericarditis were published in Circulation in 2021 by Larson. He had 8 males, 4 of these were from USA and 4 of these were from Italy. And then Israeli Ministry of Health also published 148 cases. And again, these were all predominantly males in the younger age group within 30 days, within 30 days of the vaccine. A few words about myopericarditis. So myopericarditis is inflammation of the myocardium or the pericardium or both. In short term, it can cause a compromised cardiac function, heart failure, can lead to arrhythmias, it can lead to pericarditis and effusions. But in long term, it can cause chronic heart failure and often severe cardiomyopathy or ventricular dysfunction that may need mechanical support or transplant. And it can lead to myocardial scarring, which sort of increases your risk of arrhythmias over time. Fortunately, the myopericarditis after vaccination is mild, and we haven't really seen any true clinical heart failure so far from the published literature in our own studies. This is our experience. We have had 9 patients here at Connecticut Children's with pericarditis, or excuse me, myocarditis related to the COVID vaccine. All of them had positive troponins. All but 3 had changes in the ECG, which was subtle, but they were noticeable for sure. There was one patient who really had ventricular dysfunction of 52%, and of these, only 3 patients did not have changes on their MRI, but all the others demonstrated myocardial edema or inflammation. Like many of the programs, we also developed our own protocols on how to approach these patients. So, if the patient had recently received a vaccine, they had chest pain, ECG, or troponins, we admitted them. We did serial cardiac enzymes on them. We treated them with IVIG, high-dose steroids, aspirin. And I know there's some programs that would use only NSAIDs, and we followed them. There was a good recovery in almost all of them. An example of an ECG in a patient who presented after post-vaccine myocarditis concerns, had chest pain, and you can see there's like diffuse ST elevations in all the lateral and the inferior leads. Findings on the echo, as I said, in almost all of them had normal function, but one, there was no coronary artery involvement or occlusion in any of the patients, and 2 patients had very small pericardial effusion, which could have been physiologic too, we don't know for sure. And like I said, the troponins were positive, and some of them had borderline positive pro-N-terminal BNP. This is just looking at the number of the patients and the troponin levels, so they all were positive, and they all improved too, so almost all of them came down. We also followed these patients with event monitors for 30 days, and one of the patients demonstrated this, wide complex tachycardia, which is, more than one morphology, treated with beta blockers and has recovered, and we're seeing them closely. So the next question comes is, yes, you can have some myocarditis from the vaccine. Should we vaccinate them or not? So this is a paper, it's really hot out of the press. It was just published day before yesterday in JAMA. What it showed was that, it's a very large cohort of patients who received vaccines. So, there were 3,054 million plus patients, and of that, 1,626 patients developed myocarditis. So the overall percent of that is 0.00046% risk of developing myocarditis. The other thing that they were able to find was that these were predominantly males, about 82%. The median age was 21%. And the incidence was the highest between 12 to 24 years of age. And among that, the 15 to 16 years of age had a higher incidence of 0.01% compared to 0.007 in 12 to 15 and 0.005 in 18 to 24. And, almost all of them, about 98%, had abnormal troponins and cardiac MRI. And most of the episodes happened after the second dose. And our belief is, and again, data is still evolving, is that, if you get myocarditis usually after the second dose of receiving the vaccine, or after the first dose if you've had previous COVID. This is yet to be fully established, but that's sort of the pattern we've seen. This is another slide just talking about post-vaccine myocarditis, just saying that it is safe. This is by the Advisory Committee on Immunization Practices. And, what they found was that in a case series of 7 patients, all 7 resolved and all were discharged home. This is another one where they had 15 patients, there were no ICU admissions, and that it was a benign short course. And this is another analysis looking at 63 patients. Again, the course here was mild with quick recovery and normal function on all of these patients. This is another data by the ACIP, where you can see where they've quoted some numbers, and it's important to pay attention to them, that patients with COVID infection had 16 to 18 times higher risk of myocarditis. This is COVID compared to patients without COVID. Now, the risk of myocarditis in individuals post-COVID was 6 to 34 times higher compared to those who received the mRNA vaccine. So meaning that if you get COVID, your risk of developing myocarditis is way, way, way higher than developing any myocarditis from the vaccine. So, some take-home points on this is that, the incidence of post-COVID myocarditis is low, even in boys. COVID-19 related myocarditis, or MIS-C, is probably significantly higher than the chance of contracting post-COVID myocarditis. And know that the post-vaccine myocarditis is mild. We are still assessing the long-term outcomes, but the short-term outcomes are they all do well, and it's a mild illness. And so far, the available evidence strongly suggests the benefit of vaccination outweighs the risks for all boys and girls above the age of 5 years. But more to come on this. I think that this is just another slide showing, until the November, how many people were between the 5 and 17 years of age were either vaccinated or had an intention to get vaccinated. It was about 53%, and about 25% were leaning towards, and 22% were not interested in getting vaccinated. So I think more work to do there, and encourage people to get vaccinated to prevent myocarditis and impact on the heart from all of these conditions. That was my last slide. I want to thank my team at Connecticut Children's, who have been tremendous support in caring for all these patients with congenital heart disease. We just celebrated our 25th anniversary as a freestanding children's hospital here in Connecticut. And I also want to thank Dr. Alex Golden, who's the director of our inpatient cardiology, who's shared some of his slides on COVID. He's our champion of COVID and myocarditis in children. And Philly Seller, who's also contributed to some of the slides for me. Thank you. I'm happy to take any questions. I hope I did not go overboard.
Thank you so much for that fantastic presentation, Dr. Shea. If anyone has any questions, you can just drop it in the chat or in the Q&A box. In the meantime, we have a question that came in via email. And the question was about pregnant women getting vaccinated. It says, should pregnant women get the COVID vaccine? What effect, if any, does the vaccine have on fetal heart health?
So it's a great question, but I wish I could give you the correct answer to this. So I'm a cardiologist and not an infectious disease doctor. And so my focus and practice is pretty much geared towards myocarditis in heart and how it impacts the vaccine. So I will not be able to give you a right answer there. It's a more appropriate question for an infectious disease doctor, or like referring to CDC guidelines.
Sure. We have a question in the chat. It says, would you be willing to share your slides, particularly?
Absolutely. Absolutely, I will be. Yeah, I can. Should I email it to you, Alexa, or yeah, I'll email it to you. The content is too big because of the images, so I may change it to a PDF format and email it to you.
That's perfect.
Absolutely.
So in correcting arrhythmias with ablation, are you able to restore the heartbeat to sinus rhythm?
Yeah, absolutely. We are. So there are different types of arrhythmias. There's supraventricular tachycardia, ventricular tachycardia. Supraventricular tachycardias often have two circuits, a fast and a slow pathway, either around the AV node or there's an accessory pathway. So what you do is you eliminate the accessory pathway or the slow pathway, and that the arrhythmia will terminate. If at times there are focal arrhythmia, like originating from a particular site within the atria, you can go ahead and burn that and eliminate arrhythmia and restore sinus rhythm.
Okay, and one final question that came in via email. So our life choices greatly impact our health and our heart health. What are some ways that we can stay heart healthy in terms of developing heart disease?
So I think it's a recommendation that all of us should follow, not just it's something that we tell all of our congenital heart disease patients as well, staying physically active, eating right, performing cardio, getting your cholesterol checked, staying away from things like smoking, if you have diabetes, controlling your diabetes. So all the coronary artery disease risk factors, modify them to sort of not add extra problems to a pre-existing congenital heart disease condition.
Thank you so much. Okay, it looks like we don't have any further questions. I just want to say thank you again, Dr. Shea, for joining us tonight and for a fantastic presentation. This presentation will be available on YouTube. Thank you so much for everyone for joining us tonight, and good night.
My pleasure. Thank you. Thank you for having me.
Thank you. Take care.